Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com or now flawlessmotion.co.uk for your shoulder brace requirements. Right, on with the podcast. Hello, everybody, and welcome to Glenohumeral Gurus. Today, it's my great pleasure to welcome Tash Maher to the Glenohumeral Gurus podcast. Tash, welcome. It's so great to have you.
Thank you for having me. I'm excited, a little bit nervous, but I'm okay.
Yeah,
Look
it'll
forward
be
to having the
great. It
conversation.
will be fantastic. So we're going to do two podcasts, eh, Tash? So the first one will be on AC joints, and I heard a presentation that you did at the BEAST conference recently, and it was just such a great summary of conservative and surgical management and how people make decisions, and then we'll split off into a shared decision making discussion as it sort of peels off from that and how
Yeah.
people make decisions and decision regret and what that is and what we know about that. So that will be part two. But for part one of this session with us, can you tell us about yourself and your journey through physio so far? Share with us what's been happening.
Yeah. Okay. So I trained as a physiotherapist at the University of Bradford. Graduated in 2008. And I started my career as a rotational physiotherapist in a really large teaching hospital in West Yorkshire in the north of England. Yeah, that was my rotational role, and kind of moved into musculoskeletal physiotherapy at that point. And then I moved to another trust in West Yorkshire, and kind of that's where I started to really kind of, dip my toe into more sort of upper limb and having a bit of an interest in shoulder. So I actually worked with Adele Fanning.
Oh,
She
yeah.
was working there at the same at similar time. So that was kind of where my kind of interest in the upper limb started. And then about 10 years ago, I moved to my current NHS trust, called Adele and Huddersfield Trust, again in West Yorkshire. And I moved into an advanced practice role there. So that was probably where my career started to, evolve. I was in a purely clinical role, but I kind of started to, I've always remained clinically focused, but I kind of had this interest in research and kind of, also how we make decisions with patients, and particularly when there's no obvious right answer, and kind of like exploring a little bit more about that, and that kind of sparked my interest in shared decision making. And alongside, intermingled with that, I did my master's, and I did a National Institute for Health Research pre-doctoral clinical and academic fellowship, which is where I kind of did a little bit more about shared decision making and ACJ, which kind of fits with kind of our themes for today. And that was a kind of a major step in my research career. More recently I've been looking at how shared decision making and decision regret following shoulder surgery, and particularly rotator cuff repair, how that how that's manifested, and
Mm.
also that is come together with an NIHR doctoral fellowship application, which I have applied for, but I'm still awaiting the outcome. So I think the thread sort of running through my clinical career has always been kind of clinically focused with an interest in research, but now I'm kind of feeling like I am really enjoying the research and would love to have kind of a clinical academic role in the future. And currently I'm on maternity leave, so I am not working day to day clinically for this year, but
Yeah.
I'll be returning to my clinical role towards the back end of the year. So I've still kept up some research bits and some academic pieces, but just a little break in the clinical role
Yeah, for the little
for
ones.
this year.
Yeah.
Yes. Yeah.
Which is wonderful, isn't it? And it's really wonderful to hear how your journey is taking you all these places, still with a similar thread, isn't it? I think.
Yeah.
But when you find
Yeah.
the thing that really is interesting to you, then you just keep
Yeah.
following it, eh? I'm really
I
excited
think
what's
that's
coming for
it.
you.
Yeah, I think that's it. Been really lucky to have like sort of real kind of like turning points
Yeah,
where kind of I feel like I've been kind of I've gone in a different direction than I was anticipating, and I think
yeah,
that's really nice. It's a nice feeling to think there's there's opportunities out there, and
yeah,
there's opportunities to explore and delve, and I enjoy learning, and I think
yeah.
that's kind of that's why I've moved into this sort of direction, and it's really it's really rewarding. So I
Do you
just
have
hope it
any
continues.
tips for clinicians who want to similarly follow that path? Do you know what would you
Yeah.
say? Because I think there's some really important gems in there for people, aren't there? What's
Yeah, I mean, I think, yeah, again, it comes back to, I think I've been really fortunate where I've had some really instrumental people at different points in my career that have kind of been influential in which direction I've gone in. So,
Yeah,
I suppose that's a form of formal and informal mentorship. So I
yeah,
would, really kind of, if there's people that you think actually, even in your clinical workplace or outside of your clinical workplace, that have got an interest in that, you've got a similar interest in someone, I think my advice would always be, drop them an email. Like
yeah,
actually, the worst that can happen is they say no. But
yeah,
most what I've found in this kind of, research world and in the physio world, people just want to help. Like
yeah,
people are not getting these emails all the time. It's well, some people are, but they want to help, and even if they can't help, they'll probably point you in the direction of somebody that can. So I
mm,
think mentorship, or whether that's formal or informal, I think is really important.
yeah,
But yeah, also being a little bit kind of, it's not brave, but being a little bit brave and just saying, I'm just gonna email them and see what happens. Like I've
yeah,
done that a few times to people, and it's led to collaborations, or it might not have been straight away, but later down the line, and they go, oh, I remember you sent an email that, and
yeah,
I think everybody's we're wanting to push the profession forward, and we're wanting to so we're all kind of have a similar vision in that respect, don't we?
yeah,
So yeah, I think yeah, find someone locally that will help you, support you, but also outside of that kind of inner circle.
mm,
I think that that's also important. And yeah, and look to somebody that's done a sort of a path that you think would be interesting. It doesn't mean like you have to follow it exactly, but
yeah.
actually they can give you advice.
Yeah. But
So
look at
yeah, I
where
think
this is taking you, eh? Like, look, and then
yeah,
somehow you're managing to do this and raise children, and like, oh my goodness, do you know, like, it's what a
yeah.
journey this is for you.
Yeah, I think that's and I think that's one of those, it's it can be done,
Yeah, of course. Look
and
at you.
still, I kind of feel like it was, there was a couple of things I was like, oh, and I remember speaking to Adele, like I said, I need to tell people that I'm pregnant, and and she's just like, it's fine, she's, it's great, it doesn't mean that things have to stop, like
Yeah,
you might pause things at different points, but we're going to have a long career hopefully, so that
yeah,
it's one chapter in
yeah.
in my kind of journey. So I just
Yes,
see it as a
exactly.
positive
That's
thing.
wonderful and wonderful advice, I think, for clinicians, to because when I think and I look at the opportunities that are coming your way, and some of that I don't believe is luck. Some at some point I think make people make their opportunities, like
Yeah, I think there's an element of that. Yeah, absolutely. Yeah, I had my one of my first ever meetings with my like academic supervisor, Chris Littlewood, and I was about 8 months pregnant, a couple of years ago, and he was like, "Oh, right, okay."
Okay, we're doing
He was
this.
like, yeah, he was like, yeah, but he was like, right, well, if she wants to do it at this point, then there's something in that. So
Yeah,
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 so it
yeah.
should be, there's the yeah, so yeah.
Wonderful, wonderful. Let's talk about AC joints because I think that's why people signed on.
Yeah, yeah,
So I read that paper that you published, and I thought it was a really great review. And like I say, I heard you talk at the BEST conference, and I think it was a really nice summary of all the things that have been happening in AC joints. So I really wanted just to grab some time with you and share that with our listeners.
yeah.
What do you think is important around? Let's start with the anatomy of the AC joint. Just to remind listeners where we are and what's important there. Is there anything important you think clinicians should remember?
Yeah. So I mean, I think the ACJ is a small joint,
Mm,
but biomechanically it's important. So it's really important. It's that link between the clavicle and the scapula, and what's important is that load transfer across the clavicle and the scapula, and that's important. The ACJ allows us to, the scapula to move in a coordinated way, and so I think we kind of really shouldn't think of it as a small local problem, because it's the whole kind of it's part of the whole shoulder girdle, if you like. So, and kind of when we go back to the anatomy, so the ligamentous structures are, they have differing roles, but they're complementary. So
mm,
you've got your AC joint ligaments and your AC joint capsule, which are predominantly going to help with that horizontal displacement, that rotational stability. Whereas you've got the conoid and trapezoid ligaments, which make up the corticoclavicular ligaments, which tend to sort of help with that more of
mm,
that vertical displacement.
mm.
And then you've got your kind of deltoid and trapezius around that, which, more dynamic stability in your fascia and things like that. And, I think that's particularly important when we're talking about conservative management, because I know kind of at times over my career when I've been treating these patients, you're kind of like, well, the ligaments have gone. Like, we can't get those ligaments back to their pre-injury state, but what we can influence is the structures around it, which do have an element as well, and that sort of adaptation across, the wider shoulder girdle. So,
Mm.
that rehabilitation should really focus on restoring that movement, restoring the shoulder as a whole, and I think it also the anatomy is important to have that kind of understanding of the anatomy, because
Yeah.
in some ways, because the structural appearance doesn't actually always correlate clinically that well. I don't think sometimes, it's important to have that knowledge of it. But, what we also see clinically is you could have two patients where, they've got a really similar looking x-ray, but one patient is completely painless, at 6 weeks and is just back to doing their normal activities. And somebody is really struggling, they've got a really similar radiograph, but they're struggling with cross body movements and lifting grandkids and things like that. But
Mm.
so it shows us that we shouldn't treat it as that isolated local joint problem. We should think of it as part of the whole sort of shoulder system, if you like,
Yeah.
and not treat that radiograph in isolation.
Yes. Yes. Do you think just to explore this horizontal versus vertical instability, is that something we should then, well, we'll get on to management a
Yeah.
bit different, but
Mhm.
let's talk about classification systems. Maybe it comes in there. What do
Yeah,
you
so
think then? Tell us about that.
I mean, classification systems. So I don't think we can talk about classification systems without talking about Rockwood. I mean,
Yeah.
it's the classification system that I think everybody that's listening to this will know about. Will have probably drawn it in undergraduate, and things like
Let's
that. You may, yeah,
remind people for those people
yeah,
who did it a long
yeah. So
time ago.
yeah, so broadly, your type one and twos are that very little, ligamentous displacement. Your type threes are where you've got your AC joint ligaments and your corticoclavicular joint ligament involvement. And then you've got your type fours and fives, which are, typically the more substantially displaced ligaments. and the very, very rare type 6, which I don't think I've ever seen clinically.
Yeah.
But I think the problem with traditionally what we do is we've attached treatment implications to those grades. So, type 1s and 2s are generally treated non-operatively.
Yeah.
Type 3s are historically this controversial kind of, what do we do with them? And then the type 4s and 5s are typically considered for surgery. But I think we kind of need to be really careful about turning a classification system into a treatment algorithm.
Yeah.
The limitation of Rockwood is that it never was designed really to predict outcome.
Yeah.
It's predominantly a radiographic description of a structural problem. It doesn't necessarily tell us how much pain the patient is in, how well their shoulder functions. It doesn't, ultimately tell us which treatment is going to give them the best outcome. And there's literature to support that, in that. So Granville and Chapman and colleagues demonstrated this really nicely. So they had a cohort of 77 patients with an acute ACJ injury, and they found that the Rockwood did not correlate meaningfully with pain, Oxford scores, consonant scores. So they found that radiographic grade increase didn't necessarily mean that they had an increase in clinical disability, if you like.
Yeah.
And there's also issues with reliability, so between clinicians. So, you could have one clinician assigning it as a type 3, one assigning it as a type 2. Studies have really kind of generated, the generally poor agreement between clinicians. And I think we should be really cautious about, coming back to that treatment algorithm, we should be really cautious about assigning a relatively high stakes treatment decision, particularly if you're talking about surgery, with something that is not necessarily got high inter-rater reliability. So, I mean, there's
the classifications. I mean, are there better classifications out there? Like, I understand historically that's been the best one, but does it need revising, or is it just that a classification system is not a treatment algorithm? Is that, because I think that's a really nice distinction you make.
Yeah, so I mean, there have been attempts to try and improve it. So you've got the ISACOS modification. So they kind of looked at, particularly for the type 3 injuries, that's probably where that is most useful. So the type 3A and the type 3B, and kind of their description is kind of like type 3A being the more stable AC joint, and type 3 being kind of the more unstable sort of pattern with persistent scapular dysfunction. And I think the principle of that can be useful, in essentially that it means that, it describes that not all type 3s behave in a similar way. And it also tells us that, the vertical displacement, which a lot of people focus on, is not the whole story. So I think it's useful in that sense, but, I wouldn't want to use it as a sort of a validated prognostic tool, because, horizontal instability is really, and scapular movement is really hard to, difficult to define and assess consistently between clinicians. So again, the intention is good, but I don't, I would be cautious of using it, definitively as, classification, helps us to describe the injury and communicate it with other people, but it doesn't really, again, it doesn't reliably tell us, if the shoulder does hurt, how well that shoulder is moving and what that individual outcome will be. So you kind of talked about, do we need a classification? So I think it's absolutely got, useful aspects to it, but I think my concern is just kind of saying, oh, we just treat all the type 2s like this, or we treat all the type 3s like this. There has to be some element of that individualization. And I think most clinicians, experienced clinicians, will kind of have that mentality.
Yes, exactly. Has anyone done any prognostic work in that way about which type 3s respond well, and followed them over time to see without?
So I mean, so in terms of not that I'm aware of truly kind of prognostic tool. I know there are some large trials looking at, prognostic indicators for, different shoulder pathology, but not specific to sort of the ACJs. But there's definitely lots, that we can talk about in terms of you know, what the long-term data is if we treat the type 3s non-operatively and
Yes.
operatively. There's a
Yeah.
little bit more data about that.
Yeah.
Yeah, so yeah, there's a few bits to talk about with that.
Yeah, yeah, yeah. We've kind of jumped ahead because I got a little bit
I know, yeah,
excited.
that's fine.
So
It's okay.
tell us about assessment of AC joint,
Yeah,
subjectively, objectively, radiologically. What do you
yeah.
think is important for clinicians in that space?
Yeah. Okay. Yeah. So I think, for me, assessment starts with, whether this is a traumatic or an atraumatic
Hmm.
ACJ injury. So, if it's a more persistent atraumatic injury, it's, your clinical question is going to be different. Subjectively, what I want to understand from the patient is, the mechanism, the symptom behavior, in an acute injury, is it that direct fall onto that shoulder?
Yeah.
Is it, if it's the atraumatic, is it that they've got that classic kind of repeated overhead or cross body, persistent pain? I want to know if there's any sort of instability, signs of instability, if they're getting any symptoms, clicking, clunking, things like that,
Mm.
or if they've got any visible change in the kind of shoulder contour. But importantly, what I really want to know is what the patient can't do. What's the functional consequence of that injury? That's what I really want to know from the patient. Whether is their sleep affected? Is it that they can't lift their grandchildren? Is it that they can't play tennis? Is it that they can't go back to elite sport? What is that? Is it manual work?
Hmm.
you know I think that's what I want to know, is that functional consequence,
Mm.
of this injury. That's that's going to help me guide and give me a lot of information there. And if we think about it as the subjective information being, one part of the puzzle, if you like. And then objectively, I'm looking, if it's an acute injury, you might want to look for if there's any swelling, if there is any sort of like that distal clavicle prominence, which we
Hmm.
know we see clinically. You would do your normal shoulder assessment, which I know all your listeners would probably know. You're looking at your normal, and also excluding any other pain generators. So things like your cuff, any
Mm.
glenohumeral joints, cervical pathology. You want to be looking at things like that. Um, and then when it comes to sort of specific to the ACJ, I do palpate, I do kind of load the ACJ. I think, Cadogan's work, I think she did her PhD work looking at kind of like the kind of ACJ tests. And I know
Mm.
she's been on your podcast, hasn't she?
Yeah, she
Yeah.
has.
And yeah, she talks about the test being, not, we can't put certainty on any individual provocative test, which is common for kind of the shoulder,
Right.
isn't it, in
But trust
general?
is, yeah, like in terms of
Yeah.
making a differential diagnosis, what sort of so objectively I think about in-range pain, I think about
Hmm.
maybe pain when you're shrugging,
Hmm.
I think
Hmm.
cross body.
Yeah.
Subjectively, I'm looking for pain when people are lying on them. What else
Yeah.
should I be looking for?
Yeah, I mean, those are the main things. Kind of subjectively, you've absolutely covered those essential things. I think what the kind of bit of the kind of thing that could sometimes be missed is that particularly with the atraumatic, is it's not always directly localized. We think of it classically being
Mm.
very located superiorly, and quite often it is. But I know there's evidence that that can refer into the kind of suprascapular fossa and the
Yeah.
medial arm, sometimes into the axilla. So I think sometimes that is, that kind of muddies the water a little bit.
Mm.
But yeah, just kind of like, I suppose, going back to the test, there's that there's even a more recent study, a systematic review by Krill, and they looked at the kind of a battery of tests, and they said even kind of a battery of tests only modestly improved the diagnostic certainty. So we kind of, we have to be cautious, but at the same time, it is the best we've got at the moment. So we have to, it
Yes.
does help. Again, it's another part. We're not going to solely say, I'm going to do this one test and this is going to tell me what's going on. We know that it's just another part of our assessment. So
Mm.
I think, for listeners, I think clinicians should feel a bit better about themselves if they're kind of thinking, I'm not entirely sure what I'm doing. I do these
Yes.
tests, but I'm not entirely sure what I'm doing. Well,
Yes.
actually, there is not this kind of new shiny
No.
battery of tests that's like kind of, definitively is going to tell us exactly what's going on with the ACJ that we're all missing.
Mm.
But interestingly, there was a 2025 multi-center expert consensus that was done last year with the American Society of Elbow Americans, ASES, my brain's gone. And they looked at, they showed that even among, obviously people that are treating ACJ problems,
Mm.
regularly, there was still a huge amount of variation in their practice as well.
Okay.
So, the tests are part of that information, but they're not the answers in themselves.
And the tests,
Um,
just to review for maybe younger clinicians who aren't listening, what tests are we talking about when we're talking about clusters? What?
Yeah, so the common kind of ones are, your scarf test, which is your cross body.
Hmm.
You've got your Paxino's test, which is a little bit more of a shearing type
Yes.
test. You've got O'Brien's, which would be, the resisted
Yes.
test with bin forward flexion, and you can also kind of do some resisted extension testing as well with the
Yes.
arm in 90 degrees. So they'd be probably the common ones that people would use
Yes.
alongside just palpation as well, like,
Yeah.
well palpated. But I think also with this, radiologically, that's
Mm.
another arm to,
Yes.
to the assessment is looking at the radiac. And we've talked about that quite a lot, but, in terms of the literature, and anecdotally, I think most clinicians, if they're suspecting a traumatic ACJ injury, you'd be wanting to get an AP.
Yeah.
But the literature actually suggests either a routine AP or a bilateral Zanker view, which so the
Okay.
Zanker views are the kind of AP, but with a kind of like 10 to 15 degrees tilt in the
Okay.
cephalad direction. So that just gives us a bit more of an idea of that kind of vertical
Hmm.
displacement. So that can be useful, but I know that wouldn't be the kind of routine in our hospital, but that might be, elsewhere, and it's kind of useful. That was it. The ESCA consensus by Rosso kind of
Okay.
suggested that routine practice would be one of those two views. The more difficult issue again is from a radiograph point of view is the horizontal instability. So
Mm.
really difficult to kind of assess that. Some of the literature suggests that you do an Alexander view, which is the kind of like the cross body view.
Okay. Yeah.
Um, Again, I know in our hospital that's not routinely kind of looked
Mm.
at, and I wouldn't say the evidence is there to completely change sort of
Okay.
protocols. I don't think it's
Yes.
quite strong enough there yet, but that may change in the future. I think that key message is that the ACJ assessment is just that one big jigsaw puzzle, and kind of we shouldn't solely rely on
Mm.
just the subjective, just the objective, or just the radiographs. It's kind of
Yeah,
the
piecing
whole
it
picture.
together, isn't it? And I like clinically, I think about, the weight of evidence. So I'm looking for
Yeah,
things in a subjective examination that kind of makes
yeah,
sense to this. And then if that
yeah,
marries up with what happens
yeah,
objectively and marries up then with my special
yeah,
test and looks
totally.
like
Yeah,
the imaging, then you have a bit of a complete picture of what is most likely. That's how I sort of break
yeah,
it down and think about that.
yeah,
Um,
definitely. Yeah, yeah,
Let's talk about operative, non-operative management then. I know you've
yeah.
looked at some of the literature here, and this will lead on into our shared decision making. But what can you tell us in that space? I really enjoyed that article, and again, your review at best. I thought you did a tell us what we should know about that.
Yeah, so and I kind of said sort of similarly at best, the type ones and twos, the literature's not that interesting for those. I don't think many people are kind of, operatively managing, type ones and types twos. So, the more sort of interesting debate is a little bit more, it was with the higher grade. So, I kind of touched on it before. So for the acute type three injuries, the evidence is actually now, I said, historically that was always the controversial grade,
Yeah.
but actually the evidence now is much more reliably, reasonably consistent that we can, as first line treatment, rehabilitation, and conservative management for type threes is absolutely a good and reasonable first line option. So there's a 2019 Cochrane review by Tamioki which looked at 6 trials and I think over 350 patients.
Mm.
And they found that surgery produced that radiographic reduction, but there was no clinically important difference between shoulder function at 1 year, and no clear difference with pain or return to activities. And there were actually more adverse events in the surgical group. The surgical groups, like wound complications, hardware, but there were some older surgical techniques and some lower quality evidence. So kind of, you have to take that some into consideration. And then there was also, there's been 2 big RCTs. So Windhammer and colleagues looked at the type 3s and type 5 injuries. They found that non-operatively managed patients recovered faster initially, but there was no meaningful difference at 6 months, 12 months, or 24 months. And then there was the ACORN randomized control trial, which found a similar sort of thing between type 3 and type 4s. Again, non-operative management patients recovered faster early on, but no functional advantage. But interestingly, we've also got some 10-year follow-up, randomized follow-up, which also shows no significant difference between non-operative management and operative management. They were in the type 3 injuries, and that was by Michael and colleagues. So, we can be reasonably confident from a type 3 point of view that conservative management is a good way to go.
Way to start. And do we have any predictors of who's going to fail? Do we know, and at what time point we might be wanting to check to see if they're going to fail? Because I guess manual laborers, they're off work for a long time. They can be expensive, can't they? And if we
absolutely.
Tell me about that. What do you know in that space?
So we kind of when I was reviewing this literature, the 6-week review actually was something that was coming out as being really clinically valuable. So the initial radiograph tells us what's going on, and from a very structural point of view, but it doesn't actually tell us how the patient's responding. It doesn't tell us like how they're managing with increasing load. It doesn't tell us how confident they are in their shoulder. Are they back to work, sporting activities, or things like that. So we want to, at that 6-week point, it's I think what I've found from the literature is that if we book in that 6-week appointment, we know much more at that point, and we can identify non-responders at that point. So, non-responders being, ongoing pain, ongoing feelings of instability, functional issues, if they've got any of those things that are happening at 6 weeks, that doesn't mean that rehab's failing. It just means that we might need to pivot, or we might need to reassess, do further investigations, assess if there's anything else going on. But like you say, that 6-week period kind of in the literature tends to be a really nice window that they've kind of probably got started with some conservative management. They've also had time to digest that injury, understand what's going on, talk to people around them if they want to, and we have a much better picture rather than them just landing in your clinic on that first day and going, you've got an ACJ injury, and they're kind of like, oh, what does that mean? So that's certainly something that is kind of backed up in the literature.
Okay. And what about some tips for clinicians in terms of managing these different AC joints? What should they be doing clinically? What in terms of treatment?
So I think that is a challenge because the rehab literature again isn't particularly strong. So we don't have lots and lots of high quality trials telling us that one specific protocol, is better or is more superior. We don't have these, a lot of the protocols are time based as well. So, I think we need to be kind of time aware, but not necessarily time led. We should be using, symptoms, function, to guide progression rather than time. Early on, if you've got an acute traumatic injury, it's the typical things that we would expect, in the literature that we do have. Priorities are symptom management, if we need to help with, appropriate protection, if people feel that that's appropriate, restoring that comfortable movement, without provoking the ACJ. We want to progressively load that shoulder girdle capacity. So whether
Yes.
that's, starting with your short lever, starting with your, closed chain work where appropriate, and then progressing things like your cuff, your normal sort of trapezius work, long lever,
Yeah.
and ultimately sort of moving towards the demands that they need. Actually, Levasseur, I don't know if I'm saying that correct, but they presented something called the PASS framework. So they said, kind of use that as so pain, apprehension, stiffness, and potential barriers for restoring scapular control.
Okay.
So that, I think what is quite useful about that is that it allows us to kind of say, rather than saying, what exercise should we be doing at week 4 with this patient, but actually should we encourage us to ask kind of, what's actually stopping the person progressing at this point. And I think what's also important to add in the literature for conservative management of these patients, a lot of the literature talks about restoring scapulohumeral rhythm, and it's kind of, we don't really talk about that very much anymore.
Yes.
We kind of,
Yes.
that kind of terminology, it feels quite traditional, doesn't it? But I think we kind of have to acknowledge it because that's what a lot of the literature does say. But I think, now we recognize that, there's it's normal to have variability in scapular control.
Yes.
The goal really, I think, for all the physios who start treating these patients is, we want a comfortable, confident shoulder that you're confident in, has that sufficient capacity to tolerate the loads that are important. There's also the literature that is out there also, is very much like we have to be specific, we have to be patient-centered, individualized. And return to sport actually is another area where it's not really strong. We don't have these these big protocols to kind of say, when do we get these patients returning? So, Goel and colleagues did a systematic review and they looked at 63 studies. And interestingly, I think it was 95% of them used time from surgery as a criterion. And almost all of those, that was the only criterion. So, that's kind of what's out there, is that we're still kind of in that space looking at, at 6 weeks, we're going to do this. So I think we kind of need that well-established, thinking that it should be much more individualized. We're not rehabilitating the X-ray or that bump. We're rehabilitating this person, and we need to restore that confidence and trust in the shoulder.
I've got 2 quick clinical questions around that because I want to hear your thoughts on what I'm doing. I think about trying to get some more upward rotation of the scapula because typically it's dropped away. It's not that is this is correct, that it's not that the clavicle has suddenly elevated, it's that my scapula has dropped away that then forms my bump. So I think about trying to use some scapular muscles to get scapular upward rotation, and I try to do that early. I think that's what I've been doing. Where I've also struggled is trying to this trapezodeltoid fascia. I'm supposed to be loading that, to give some sort of compression. Have you got any tips there? I've sort of struggled to do that pain-free with some patients. And I've tried short levers and I do lots of isometrics. I really, it works pretty well for instability patients. But then what am I doing wrong there? I struggle there.
I mean, I don't think you're doing loads of things wrong there. I think, it is a struggle, and there's not, certainly in the literature, there's not that kind of, golden kind of nugget
that's
one exercise where we kind of do this and then it's fine. So you're completely right that, we should be looking at trapezius, and I know like upper trapezius is kind of, it's a little bit of the enemy sometimes, isn't it? We kind of spend, I know Alison was talking about this, that kind of that that we tend to just kind of dampen that down, but actually that can be really useful in activating upper traps with these isolated ACJ injuries. We can, that can be useful, but it's just about very early on trying to activate it. So adding some external rotation where elbows on the table, even just that, having a little bit of activation. So getting some real kind of like stability around the scapula. as well as kind of, the movement. And I think I would do that very, very early on with patients because it's not provocative. I find that they don't mind it, and they can do it at a desk. They can do it whilst watching TV. Or anything where you kind of close chain, but adding a little bit of external rotation of the hands. It's going to activate your cuff, but it's also going to, activate, some of that lower traps as well. And in getting, from a bit of a proprioceptive point of view as well. But again, it's not particularly provocative or painful for them to do. You can progress that from, very kind of a seated position, but then into kind of a press up position, as they get happy, as they're more confident in the shoulder. So I don't think you're, I don't think there's that kind of like, perfect answer like anything in the shoulder. That's why we like the shoulder, isn't it?
It's fascinating, isn't it? Yeah, no, and it's good to think, because I don't think so much about cuff or loading external rotators, but you're right in terms of what else happens with that movement, is what I'm hearing from you. So that's a really nice tip. In closing, what do you think is the most important things that clinicians should remember about AC joints? What do you want them to, because you've got such a wealth of knowledge and reviewing all the literature and what's happening here. What do you want the take homes to be here?
I think probably the most important thing that I want people to recognise is that ACJ management is much more than the Rockwood classification it's assigned, and and much more than that initial radiograph. I do think probably more than any other shoulder pathology that we place a lot of emphasis on the radiograph in ACJ injuries, because it does have that classification. It's not like a cuff injury where you don't have a classification for that. We use much more, there's much more kind of tailored and individualization with those, but I think we kind of emphasize that a little bit too much. And we've talked about the fact that imaging can characterize injury, but it doesn't necessarily predict pain, function, or outcome. I think we can reliably say that if we've got these type 3 or around that area, we can reliably now say that actually first line treatment conservatively, I think is absolutely acceptable. And that's probably a change in thinking. We have to also recognize there's still uncertainty with the type 4s and 5s, particularly translating that to patients, so making sure they're aware that there's uncertainties. There's not this kind of wealth of literature supporting our decision making. It's got to be individualized. I think as physios, we've got a really important role. We often have the advantage of seeing patients over a longer period of time, so we don't always see them at one single time point. So we can assess how these patients are moving and how they're tolerating things. And good physiotherapy should recognize when the patient's doing really well, but also recognize when the patient's not doing so well, and having that ability to change and kind of go, actually, no, we maybe need to switch this up a little bit, and having that kind of mentality. Being comfortable with uncertainty, I think, is also important. That rehab literature, like I said, it's not quite there. We don't have, that literature to support everything that we're doing with ACJs. So perhaps the message is don't be overly influenced by, how dramatic the initial x-ray looks. We shouldn't kind of just go, oh God, what's going on with that? Like that, whisk them off for surgery straight away. Rehabilitate them well, individually, use the clinical trajectory to kind of help guide the pathway. And the main goal shouldn't be to kind of restore that radiograph, and it's to help that person have a shoulder that they can use and is for the things that matter to them.
That's wonderful. Wonderful. Hey, well, thanks very much for your time. That's a really great review of AC joints. So what we're doing, we'll wrap up this now, and then we'll come back for part 2 on shared decision making. Thanks, Tash. It's been great.
Thank you.
And thanks again to Flawless Motion for supporting this episode. So if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment and rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.